The topic for today's discussion is molecular diagnosis of genetic disorders. This will cover the types of disorders and the test available. There are several types of patients that have come to the genetic clinic of this Williams syndrome, holoplatin, Prader-Willi syndrome, patients with skin lesions, dysmorphism, xeroderma pigmentosum, skeletal dysplasia, newborns, Down syndrome patients, and short stature patients, patients with positive fish, antenatal patients, and also some ward patients are seen in the genetic clinic. What is the need for molecular diagnosis? The main aim is to detect mutations in the DNA, to confirm the diagnosis and enable antenatal counseling. The unusual origin of PCR is well known. High throughput technologies have enabled better molecular diagnosis in suspected genetic disorders. Apart from common disorders, testing can be done for rare disorders and various syndromes. And there are common molecular tests: allele-specific PCR, ARMS PCR, PCR, RFLP, GAP PCR. The common genetic disorders for which testing is done include Down syndrome, thalassemia, DMD, sickle cell disease. Newer tests like real-time PCR, QF-PCR, MLPA, microarray have enabled better diagnosis. Selection of tests will depend on size of the gene, type of mutations, presence of mutation hotspots. If the size of the gene is small, then easier diagnosis is possible. If the types of mutations are point mutations, these are detected by allele-specific PCR or RFLP. And mutation hotspots, this can be detected by other methods. Large deletions, duplications require chromosomal microarray analysis, and duplications can be seen in several disorders. This is one example in which the child came with dysmorphism and intellectual disability, and microarray done showed 16p13 duplication syndrome. Workup was done in the mother to find origin, and she showed 1516 translocation. And the type of disorder will determine the diagnosis. The next-gen sequencing has now come and made diagnosis easier, and the prototype disorder, Gaucher disease, presents with failure to thrive pallor. In the index case, the child presented with abdominal distension and pallor, and there were also two other sibling deaths in the family. Systemic examination showed hepatosplenomegaly and hypotonia. CVS was normal, bone appearance enzyme was deficient for beta-glucosidase. Type 1, type 2 Gaucher are usually seen. Type 3 usually come in childhood. Treatment approaches include enzyme replacement therapy, substrate reduction therapy. Prenatal diagnosis and newborn screening is also available. There is 25% risk of recurrence since it is a recessive disorder. In another family, a consanguineous Muslim family from Jammu and Kashmir with suspected Gaucher, there were two deaths at around 4 to 5 years of age with hepatosplenomegaly. There were no hospital reports or papers available for the previous death. Mutation analysis was first done in the parents for Gaucher disease, and siblings, one 10-year-old male and a 3-year-old girl presenting with hepatosplenomegaly and anemia. Enzyme analysis revealed borderline low enzyme levels in both the brother and sister from different labs. Sequencing was done on Illumina platform, and variations were analyzed and interpreted with available bioinformatic platforms. Several genes were tested which were associated with Gaucher disease, including Gaucher genes, and a known homozygous pathogenic variant at protein level leucine to proline change was identified in the GBA gene in the brother of these two siblings. And this confirmed the diagnosis of Gaucher disease. This is a short poem which is on DNA, and this shows that nowadays many tests are available, can be easily done, and good labs are.
Here comes the DNA. Who says the test is not available? Decide what is to be done, and Srini will do it for you. Be it microarray or fish, you just have to say cheese. Good labs do perform. Remember to fill the form. Look, the NGS comes with a tap. Loosen your pockets to fill the gap. Wait for the report and take it easy. Dude, geneticists have become busy.
Some more examples are here shown in the slides. For hemophilia, first the detection of inversion mutation is done, especially in inversion intron 22. And if this is negative, then linkage analysis can be done with the use of dinucleotide repeats or RFLP repeats. And then this can be followed by screening for point mutations and sequencing if needed. Similarly, for DMD, one has to do the testing either by identification of the different deletions, duplications in the different segments or hotspots, and or one may do MLPA testing, which is available in many labs nowadays. In case of next gen sequencing, this is available in limited number of labs, and however this can be done in many disorders, and if differential diagnosis is known, it can be done for several disorders. Nowadays there is concept of genomic disorders in which deletions, duplications, copy number variations can affect the phenotype. Thanks.